great to be here, and this is my first time at this meeting, and I know I've learned far more than I'll teach you in the next half hour. What a wonderful group of individuals, and I know that I haven't spent enough time listening as hard as Cindy told me that we should be. I got a lot out of our group today, and I hope that this is just the beginning of us as physicians doing a better job at listening to what our young patients and then older patients are telling us to do. So I hope this will be a great partnership. Pamela has been a wonderful partner in the India trips, and she constantly reminds us why we're there. It's not a matter of what surgical technique that you're doing. It's what we're trying to do each step by step to try to improve the lives of children. And I'm not sure that we always get it right as surgeons. Now I have a brief presentation about sexual health. I think it's wonderful that we get to talk about sexual health, because there's a long journey that that you have to accomplish along the way. And my gosh, I mean, I don't need to tell that to anybody here, but you don't even get to think about sexual health unless you're dry, unless you have the confidence to engage in a friendship. And we are so focused in the nuts and bolts and the weeds of the reconstructions, just trying to struggle with the continence part, that I think we often miss it. You've all seen, I mean, how many of you have seen a bladder exstrophy that hasn't been closed? Has everybody seen one that hasn't been closed? So you have. This is a boy with bladder exstrophy. This is where the umbilicus was. That's been resected. The pubic bones are separated. Mike Mitchell likes to call this a hernia, where the pelvis is opened up. And our job, and it's sort of a crude operation that we do, is designed to put all of this back inside. And we work awfully hard at it over a 12-hour period sometimes to get everything inside, to get every stitch in just the right spot, in part because we don't know as much about this as we should. We're working very hard right now to try to standardize the operation. There are several ways, modern ways to do the operation. We do at CHOP, we do the surgery as does Brad Kropp and I think Tony, as a complete repair. I was taught the modern staged approach during my fellowship at Johns Hopkins, and that's where I got my start. I don't know whether what we're doing is going to be any better than that. I have no idea. The one curse that we have as pediatric urologists is that we have only one life to lead, so that the children that I'm operating on now will be coming into their adulthood when I've retired. And so there's a real downside to that. And I think that the major exstrophy programs now are staggering their team in such a way that we have a leader and then the next surgeon about 15 years behind, and then the new surgeon about 15 years behind that period. And so that over the span of 3 decades, you can have an experienced exstrophy surgeon always in the works. And the main problem with that is that we only get to do 10 or 12 of these operations a year, aside from our India experience, which sometimes doubles that experience. But in the end, with a complicated problem like bladder exstrophy, it would take thousands of these operations for us to get really good at it. Those of us that do bladder exstrophy also, as a sidelight, do hypospadias reconstruction, other types of perineal operations. I think I'm just beginning to get the hang of hypospadias surgery, and I'm sure I'm close to 2,000 of those operations. And none of us are going to get really good at this unless we're careful to listen to all of you and careful to listen to our colleagues. And that's one of the reasons why I think you'll see over the course of the next few decades that centers will begin to bind together and work together as we have with Boston and Wisconsin to try to learn a little bit more about this. But that's not really the purpose of my talk. It's just to outline the types of complex problems that occur in addition to the bladder being exposed. And there's a variety, and there's danger in reporting data without segregating patients with bladder exstrophy from epispadias and patients with cloacal exstrophy from bladder exstrophy, because the degree of difficulty, if you will, on the outcomes will depend on what the initial problem is. If we take one of an anatomical drawing with regard to the continence piece aside, of course, driven largely by good bladder function and function of the intrinsic as well as the extrinsic sphincter, that is the one that you have no control over, or the one that allows your urine to sit in the bladder regularly without thinking about it, versus this is the muscle that allows us to stop our urinary stream if we're startled or have to stop voiding. This whole area, if you remember, is exposed in the male with bladder exstrophy and also in the female. What makes it more complex for the male, of course, is that not only that, but the bulbar cavernosus glands, Cowper's glands, are exposed. This bulbar urethra here is a very complex muscle that is involved with ejaculation. All of that is exposed. And so all of that is touched by a surgeon. And on a good day, we get it just right. And on a bad day, we get it sometimes pretty wrong. And then sometimes we'll have a reasonably good day and it just won't heal properly for us. And so your best shot is to have it work well the first time. And we continue to experiment with these things. There's just not enough patients with bladder exstrophy that are funneled. I suspect that we would be getting closer to a critical number if all of the babies born in the United States went to 3 or 4 places, but that's not always convenient for families, and it's not always well recognized by insurance companies. But I believe that in probably not my lifetime, but my professional lifetime, but perhaps in my lifetime, we'll see this happening more and more. And I think it will take a commitment on behalf of the exstrophy surgeons and also on insurance companies and patients, but we'll get there. And if we get better and better at the operation, we'll get better and better at the sexual health, because I think that's really the coup de grace of this. If you look at the female pelvic diaphragm, here is the levator ani muscles in a normal patient. Remember, bladder exstrophy, the bones are separated pretty substantially. So instead of this being a tight sling like this, it's more of a hammock. And so as you get progressively further anterior or forward, the urethra, for example, is not nearly as well supported by this pelvic diaphragm tissue. And therefore, the ability to close that sphincter muscle off, the wrong way, to close that sphincter muscle off, this is that sling that I was telling you about. Those are the sling muscles there. And if they're in a sling like this, as opposed to hugging the urethra, we don't expect to get the same ability to clamp down on the urethra and stop the flow of urine. So why am I going into so much detail when I'm talking about sexual health with regard to urination? Well, I mean, I would submit to you that if you're soaking wet, it's very difficult to get into a good relationship with a partner. It's hard to develop the confidence that's required to enter into that relationship, particularly nowadays when young people, I think, are, now I don't know, I have 2 20-year-old daughters, and I sure don't hear this from them, but maybe my wife does. But I understand that the sexual milieu now is much more relaxed than it was even when I was going through school, which is far more relaxed, I'm sure, than when my parents did. But it makes it a little more difficult for the boy or girl with bladder exstrophy to get into a casual relationship, which is where I think the morality aside, where I think a lot of the learning and confidence comes from. Now, here's a diagram taken from John Gerhardt's excellent work that was published in 1994, where they were looking at the angles of the separation. These patients, the bladder exstrophy patients, on average have about 12 degrees of separation of the iliac wings and an additional 18 degrees of separation of the pubic bones, with 30% shortening. And that results in the male in a, instead of the normal situation where these bones are together, you have a separated crura. You know, these are the erectile bodies of the penis, the hydraulic bodies of the penis that cause an erection. They're more separated. They're also shorter and broader, so that males with bladder exstrophy have a broader penis that is not as long. There's also a dramatic upward curve to the penis. And so as you march through the repair, the staged repair or the complete anatomical repair, there's a series of surgeries that get done, and they're all designed at first to provide for good continence. Fortunately, the osteotomy surgery that we feel, at least those of us that are doing the complete repair, are important, also can help to pull the pubis together and provide additional penile length. But in the end, even after a good repair, men with bladder exstrophy have about 20% shorter penis than normal men. That doesn't by any means mean that men with bladder exstrophy are going to have difficulty with sexual activity. But in my experience and in the literature, there's a strong suggestion that that men are going to be much more cautious about entering into relationships to begin with. These are the reconstructions. I'm showing this as a description of the epispadias repair. These are drawings from an early publication at Johns Hopkins. But basically what happens is that the urethra here, after being taken off of the dorsum, or the upward part of the penis, is rolled into a tube and then pushed into a ventral location on the bottom of the penis, which is normally where the urethra is. And then the urethra is closed over the top, which transports the urethra into a more anatomical location. And then in our hands, this is done during the initial closure. Now, we didn't talk too much about this today, but one of the reasons why the complete repair has not been more widely accepted is that there have been at least 26 reported cases of penile injury that's occurred because of overzealous dissection during this 12-hour operation that's difficult to do. And those of us that have maintained our interest in the complete repair have in one way or another worked to make this a safer operation, and that may include working with skilled co-attendings, that both of whom are skilled exstrophy surgeons or have a great deal of interest in exstrophy surgery, so that we're not operating with a resident or a fellow who's never seen the operation before, so that you can move through the operation more quickly and reduce the fluid shifts that occur during the operation to result in better outcomes. This is our patient at Children's Hospital. This child was operated on as a newborn. 2 weeks after my predecessor, CHOP, died. I was exhausted. We started this operation at 9 p.m. We finished it just in time for me to go to clinic the next morning. That was the last operation that I did as a newborn, did the complete repair as a newborn. Now, this child's going to do fine. He lost a little bit of the glands on the left side, but these types of things happen, and I don't ever want it to happen to me again. When this occurred, I went out and recruited an exstrophy surgeon to work with me. He was on site 6 months later, and we never operated again on a newborn with bladder exstrophy. We treated them all with osteotomy, which took the urgency of doing the operation in the newborn period out. It allowed us to have the same orthopedic surgeon each time, the same nursing team each time, the same 2 surgeons each time. That's what we did at CHOP for the next 15 years with much better results. But those are the types of things that you can only do if you take a real direct approach to the surgery for bladder exstrophy. Can't be done in an ad hoc way by people that only occasionally get to do the surgery. It's a lot of work through the years, through the toddler years. And here's Philip Ransley. How many of you know who Philip Ransley is? Just a few of us. So Philip Ransley was the principal surgeon at the Great Ormond Street for about 30 years. His exstrophy series is as big as many. But in 2005, when I was with him at a meeting, he asked a crowd of 400 Brazilians if they'd ever met anyone, an adult male with bladder exstrophy who voids normally and is dry day and night, who ejaculates and has normal sexual function. And I don't know the answer to that even to this day. First of all, I don't know that any of us can define what normal sexual activity is. I know that many people with bladder exstrophy have healthy sex lives, have a family. But I know, and one of the most compelling things about being an exstrophy surgeon is that I get to spend my days with people that have dealt with adversity and know how to get beyond it. And I think that probably is what brings us who are committed to bladder exstrophy surgery back week after week after week to do the surgery that we think can really help you. But this is the type of thing that I think brings us back to the drawing board, makes us want to get coaching, makes us want to work with groups. So some of this is a little bit of a disclaimer going forward, and that is that some of the data that I'm going to show you is discouraging. But I have 2 choices here. One is to put a good spin on it for you so that everybody feels good, but I don't think that does me any good. I'm a warrior, I know. I was one of the guys that put my hands up and said, I'm a warrior. I think that if you have a surgeon who isn't a warrior, you're probably in trouble. There are various degrees of worry. If I was really a warrior, I wouldn't go to the operating room at all. On the other hand, if I didn't worry, I probably wouldn't be prepared. And so I'm going to tell you the honest truth about what the data shows with regard to sexual health, and then I'm going to tell you why I think we're going to get better at it, and I'm going to leave you with some hope because what I think is happening more and more now is big groups of people are getting together, and when you put a lot of minds in one room to work on one little itty-bitty problem, we usually get better at it, and we will. So what does a male need? A friend. We talked a little bit about today's social milieu. So I'm going to tell you that I think we better have the continence situation pretty well wrapped up before someone's going to go out and try to have a family who has bladder exstrophy, particularly male. I know there may be some exceptions to that, and perhaps we can discuss that during the panel. Men develop relationships later, but they can be satisfying and productive. I know that now. I'm old enough now. I've been doing this long enough now to have my own group of adults that I operated on when they were babies, and little by little, they're getting there. I have a young man who's a tennis star who had a pubic epispadias who fell in love, and he would come into my office, during his teen years, and I'd always schedule him last on a Saturday. We have a Saturday clinic once a month, and I'd always schedule him last on a Saturday so that we didn't get any further behind. And I would sit for as long as he'd want to talk about this, and we'd talk about various types of handicaps and all that. So he called me about 6 months ago and said he'd met the girl of his dreams and that he was ready to try this out. And what did I suggest? And we worked our way through the right condom selection, and so he's done very well, and he's still with his girlfriend. I checked in with him, and they're doing fine. And so you can certainly get beyond that. But anatomy and physiology are important, and all of the surgeries that go on in the first 5 years of life are designed to develop a dry patient who can empty his or her bladder, and and hopefully we can do that with a minimum of scarring, so that the self-confidence that comes with adolescence and the concerns that come with adolescence can be minimized, but we're certainly not there yet. We talked a little bit about this. Penile size. My gosh, I remember that I didn't want to go to school if I had a blemish on my forehead. And so, the adolescent years are horrible. And I've never experienced it. I'm not a trained psychologist or social worker. But I feel the pain that these guys and girls are going through. And the adolescent years are tough, really tough. If you can make it through those intact, then I think people start to get a little more reasonable, and the relationships that you get involved with get better. And I've seen this happen enough now that I can speak with firsthand experience. We need to produce a straight phallus that's as long as we can. We're experimenting a lot now in these newborns with testosterone stimulation prior to the first repair, along with external rotation of the corporal bodies to correct the curvature and move the penis into a more dependent location, which is a ways away from the mons pubis and the fat pad that develops in that, which I think is providing for a better cosmetic result. But I learned that 2 years ago in India. So I'm going to be done before I see how well those 20-year-olds are doing. So Dana Weiss is going to have to report on that. Little things like fitting a condom. Here's a website that you can go to. This is a British company that actually their whole line of work is making a whole line, 12 different sizes of condoms. That seems like a trivial thing, but that was one of the most difficult things that I had to manage with this young man who I care deeply about. And he was there. I mean, it was no problem. But obviously, I'm not going to send him out into the war without protection. So the female condom is another thing that can be used, but there are difficulties with that. I don't have enough experience with that to be able to tell him with confidence exactly how to use it. The urethra. Now, we frequently, particularly if we treat with testosterone during the first repair, we'll frequently separate the urethra from the glands of the penis so that we create a proximal hypospadias from the epispadias, which I think provides a much longer, straighter penis, but then we have to build the urethra out. So, and we try to get that done by the age of 4 or so, once we get an idea of what the continence is going to be like. We talked a little bit about emission, and emission is the front loading, if you will, of the sperm via the ejaculatory duct, which is at the just north of the prostate, just inside of the prostate, and then ejaculation, which is this rhythmic contraction of the urethra. Now, if you have a patient who has a bladder neck that doesn't completely coapt, you can have a condition called retrograde ejaculation, so that there may not be very much ejaculate that comes out, and instead it goes the wrong direction into the bladder. And you can then, there are ways to treat for that. You can spin the urine down and capture the sperm and artificially inject that. So there are lots of ways to get around some of this. Just to go back to the anatomy, the good news is that the testes should be just fine. Remember, anything north of this point or so is okay, because we start our close dissection at the bladder neck, and this entire area is dissected free. But the vas deferens enters the seminal vesicle at this point. So unless you're really aggressive with the prostatic dissection, that should be intact. I have no doubt that in earlier reconstructions that area may have been harmed, resulting in patients with no sperm at all, because the scarring resulted in injury to that area. Even in that situation, though, with modern techniques, you can harvest the sperm directly from the testis as a biopsy and use artificial insemination techniques to inseminate the spouse. So that can be done. The good news is that the hormonal system should be just fine, and the testicles should be just fine. So if you can collect the sperm, then you should be able to theoretically deliver it properly. So it's the plumbing, that's the problem. Now, John Gerhardt is not here right now. He had to get back, but he was kind enough to share with me some of the data from the recent from his series. Now, this number, the 1,248 patients in the Exstrophy database. When I first put the database together as a fellow at Hopkins, that number was just under 300. They have a tremendous experience at Hopkins, and they've led the way, helping us to learn more about this problem. And little by little, we're making steady progress, whether you measure continence or sexual function, and we'll continue to make progress. But he had a series of 215 males that were over 18 who had completed reconstruction. And of that group, there were 113 that responded, 53%. That shows what a committed group of patients, Exstrophy patients, are. You rarely get that kind of a response on any sort of a sexual type of questionnaire that's sent out. Usually it's about 10 or 12%. But people with bladder exstrophy are keenly interested in helping others with bladder exstrophy. And I think, there's plenty of examples of that in this room. The mean age was 32. 96 were sexually active, or 85%. 32 had attempted pregnancy, or 28%. 23 were successful. 31 had fertility issues, but only 4 had this azoospermia, meaning that there was an injury. So if you look a little more carefully at the data, and you look at the quality of the sperm, you can see that fully 36% in their ejaculate had normal counts. The number for normal men with no problem at all in the United States is about only 93% have normal results. And patients, for example, with an undescended testis, one undescended testis, only about 70% of those individuals have normal sperm counts. If you have 2 undescended testes, the number is about 50. And so, so as bad as this sounds, to me, this is cause for celebration, because this means that with modern techniques, everybody with bladder exstrophy can have a family. Unless they have some primary testicular problem that 7% of American males would have. So it really does come down to the plumbing. Is it a straight penis? Is the urethra out at the tip of the penis? Is the ejaculate going in the right direction? I also thought that sexual frequency, this is pretty good news, I think, that almost 50 of these individuals over 40 were having sex weekly. Now, the American male, when you poll them, probably exaggerates that figure, whether they're exstrophy or not. But that's been my own personal experience with the hypospadias patients I take care of. And the other thing that you don't know for sure about is paternity. Because there are lots of different ways to have a family besides your own ejaculate and your own, and so these data are a little bit tricky. When we did a big series in patients with cryptorchidism in 2000, we had a couple of patients that had 3 children who came in, couldn't have a 4th, and were azoospermic. And I'm sure they'd been azoospermic all along. And so sometimes the work gets done and nobody knows how. And we got out of the business. We stopped that. I don't know why we were silly enough to think that was a good idea to do DNA testing on all these people. We stopped the project with that guy because we thought, that psychological harm that would come to, a few of the patients would be challenging. So, the bottom line is you can't believe everything that you read, and people want to please their surgeons. So if you want my absolute honest feeling about this, I think these numbers are probably slightly higher than are really out there. On the other hand, this is a major improvement over what we were reporting even 10 years ago. And so we're getting there. So to summarize for the males, relationships become later. You know, from where I'm sitting right now as a 59-year-old man with a 24-year-old son and two 20-year-old daughters, I say, great, let them start a little later. The relationships are also more monogamous, and I think it's because by the time a man with bladder exstrophy finds a woman that he trusts, he sticks with her, and she does him as well, and which I don't think is such a bad thing either. And so these two things, I'll be fine if we don't fix those two things. Sexual function is clearly possible. It may require some ingenuity and patience. We have a great physical therapy group at Penn that help individuals, males and females, with sexual intercourse and issues like that, with painful intercourse and with difficult intercourse. If you look hard, you'll find some good people at any major center who can help with that. Pregnancy is possible, may require some work. And I just put this in, this is another paper, Park's paper from 2015, just recently published in the Journal of Pediatric Urology, was very, very similar to what John Gerhardt's data showed. So it's not just Hopkins that are getting these numbers. And I think there's cause for celebration here. So there's plenty of hope. Now, fortunately, in the females do much better with this. The vagina is a little bit shorter in the female. That's not a problem. The perineum is a little bit different. The distance between the umbilicus and the introitus in the female is shortened. So in our initial operation, we try to move this whole unit, the urethra and the vagina, posterior, and that helps quite a lot, I think. Stenosis, narrowing here and here, is very common after the initial operation. We don't usually work on that until the patients are into their adolescence. In my experience, it's not been very difficult to take care of that with either a flap that can be taken from the buttocks or a local flap from the perineum to open these areas up. Females should have normal fertility. Oh, sorry, thanks. So time to wrap it up to stay on time. About 68% success rate. 43 pregnancies and 28 women at the Institute of Urology in London. There were 43 pregnancies, 28 women, 4 spontaneous and 4 therapeutic abortions, but 34 live births. So the females actually are doing quite well. Just a few words on the delivery. In my view, it should all be done by C-section because the delivery, natural delivery, I think, jeopardizes a lot of the urinary continence work that's been done. And there are long-term consequences of prolapse, I think, that happen a little less commonly in those that have had bladder, that have had osteotomies early on. But that is a real issue as patients age, and various types of slings can be effectively used. So I think that in females we can be even more encouraged. And I mentioned that one of the frustrations for me is that I've only got one shot at this, and when you operate on a baby, you're never absolutely sure how they're going to do. By the time you get good enough at this that you can be proud of your results, you're old enough that you're not going to see those patients grow. And so that's a little bit of a shame, but we have young partners that'll keep this up for us. But I would also say that for me anyway, you all are our partners as well, and the confidence that you have all provided us as surgeons over my career anyway, the ability to roll the dice a little bit with us when we take you to surgery, because we don't profess to have all the answers, has been astounding for me. And so I thank you for your confidence in us and your enthusiasm in helping to encourage us as we work together to get better at this. So thank you for a great meeting. And Pam, thank you for an outstanding job. And Bradley, thank you very much for the hosting.